Very good morning, one and all. So today I have chosen a topic of isolation precautions. So most of my talk will be based on the CDC guidelines which came in 2007 and it was recently updated in May 2022. There are few things which I felt important to discuss again, revisit and discuss again. So that's why I have chosen this topic of isolation precautions. So before going into the proper topic, I'll just brush through the basics of microbiology which we used to teach even the MBBS students. Transmission of infectious agents. So we know for epidemiological purposes an infectious agent to transmit from one person to another person or whatever, it needs three elements. So source of the infectious agent is always needed, and in the hospital healthcare environment most important source is usually the human source. So the human is a person who is easily roaming around everywhere carrying plenty of microorganisms in himself, either with symptoms or without symptoms. So humans are the most important source of transmission or source of infectious agents in the healthcare environment. So which includes mainly patients, healthcare workers and visitors who comes to the healthcare area. Apart from this, inanimate environmental sources. So fungal spores, presence of fungal spores in the construction area and other areas. So those will contribute to these environmental sources. So susceptible host, that is the second important element. A person who is exposed equally, two different persons exposed equally, but the response and output can be quite different. So it depends on multiple factors, all these things. Like it depends on the agent factor also, like pathogenicity, virulence, infectious dose, route of entry, etc. As well as the immune status of the person, medications, the previous surgical procedures, or radiation therapy, or presence of indwelling devices. All these factors decide whether the person should get the disease or not. And the mode of transmission. So these are the common modes of transmission widely accepted, like contact, through contact or droplet or airborne transmission. So if we go into the modes of transmission further, contact transmission. So this is the most common mode of transmission of infection in the healthcare environment. Compared to droplet as well as airborne, the most common mode of transmission. It has two types. One is direct contact transmission, another one is indirect contact transmission. Direct in the sense, blood or body fluids directly comes in contact with the mucous membrane or a unintact skin. Mites presence which leads to scabies from a scabies infested patient, easily it can transfer from one person's hand to another person's hand by just direct touching. Herpetic infections on the finger of healthcare provider after oral care to the HSV persons without a proper barrier precaution. So all these are direct contact transmissions. Indirect contact transmission, always there is another object, another fomite or another object which transfers the infection from one person to another person. There is no direct contact as such, but from one person it comes in contact to some substances or articles. From that article, the other person gets the infection. That is indirect contact transmission. So contaminated hands of healthcare worker, that is one of the single most important factor which decides, which leads to indirect contact transmission of infections. So patient care devices which is shared by many patients usually, like thermometers, stethoscopes, shared for many patients, these are also indirect contact transmission. Instruments like endoscopes or surgical instruments, even them can lead to indirect transmission. Contaminated clothing, like apron is being worn by many doctors, which can come in contact with the patients, multiple patients at a time. So those kind of clothing also can lead to contact transmission. About droplet transmissions, we know when the droplets are usually formed, like coughing, sneezing, even talking can generate droplets. So some procedures like suctioning or endotracheal intubation or pulmonary resuscitation, all these things leads to droplet formation. So we know the basic that droplet size is usually considered to be more than 5 micron in size. There are quite few interesting things which I found in that article which I would like to discuss. Historically, we always had a feel that if it is a droplet that is more than 5 micron in size, it will not travel more than 3 feet. So that was the historical thing which was defined. So a distance of less than 3 feet around the patient. But is it true for all kind of droplets? Is it true for all kind of infections? So here comes the question. So for smallpox, they have done experimental studies with smallpox, and as well as during the SARS outbreak in 2003, a lot of studies had happened. So they found that both these infections are transmitted usually by droplet. But it can travel more than 6 feet from their source, and it can even lead to infection more than 3 feet. So even though they are a droplet, they can travel more than 6 feet distance. So that is there. And observation of particle dynamics. Particle dynamic studies are also had conducted, and they have shown that more than 30 micron size droplet can remain suspended in the air. So we have the belief that it is less than 5 micron, more than 5 micron, it will not cross 3 feet. But there are studies which have clearly proved that it can go till 6 feet, it can even go, it can even remain suspended in the air even if the size is more. So then how does it matter? So maximum distance for droplet transmission is currently unresolved. That is the guideline says. So how do they divide then? How do they say that this is droplet and this is airborne? How do they have that conclusion? Is mainly because of their infective nature. So these kind of organisms which are transmitted by droplet, they do not remain infective over long distances or over long time period. So if it travels more than 3 feet or more than 6 feet, usually it will not remain infective. That's what they say. Even though the droplet can transmit, the organism may not remain infective over long distances. So because of that, there is no need for special air handling or ventilation unit system for droplet infection. So organisms which are commonly associated with droplet transmission are Bordetella pertussis, influenza virus, adenovirus, rhinovirus, mycoplasma, even SARS-CoV is considered to be a droplet transmission infection, group A streptococcus and Neisseria meningitidis. So all these are considered to be a droplet transmission organisms. What about respiratory syncytial virus? Can you tell me like what is the common mode of transmission of respiratory syncytial virus? What is our common field? It's a respiratory infection. So obviously it should be droplet. But the most common mode of transmission for respiratory syncytial virus is contact transmission. And to talk further, there is an overlap between droplet as well as contact. So what is the contact? Blood or body fluid comes in contact with the mucous membrane. So blood or body fluid, even a droplet, it can be like a body fluid or a secretion. It comes in contact with the mucous membrane and then leads to infection. So it's kind of a overlap here. So respiratory syncytial virus, it can be a droplet, but the most common mode is actually contact transmission. And there is another nice phenomenon which I had gone through here is cloud baby and cloud adult phenomenon. So there were studies and where it is proved that Staphylococcus aureus can be transmitted even by droplet. So we all know it is usually transmitted by contact transmission. It spreads by contact, touching from the healthcare workers' hands. But some studies have proved when the infants who are infected with rhinovirus infection, the newborn infants with rhinoviral infection, they had spread Staphylococcus also during the period of infection. So it was quite documented, and later another person had studied in adult where he had reported that almost more than 40% increase in chance of transmission for Staphylococcus aureus was documented if the person is having a rhinoviral infection. So the presence of upper respiratory viral infection leads to increased transmission of Staphylococcus also as part of droplet transmission. So that is what is documented. So it is, this phenomenon is named as cloud baby or cloud adult phenomenon. So airborne transmission. So we know that size of the droplet should be less than 5 micron to call it as a droplet nuclei. So it contains infectious agents that remain infective over time and distance. So that's a key difference between the droplet and airborne. So size is one thing, and it remains infective over time and distance. That's another important thing which we need to know. So requires the use of special air handling and ventilation system. So it needs extra handling for the proper control of air and ventilation system. The organisms which are known to be airborne transmitted organisms are like Mycobacterium tuberculosis, Rubeola virus causing measles, and Varicella zoster causing chickenpox. So these three things are clearly documented to be an airborne transmission. So other organisms like influenza virus, rhinovirus, and smallpox. So influenza rhinovirus, we just now saw that it is a droplet infection, but there are studies which have proved that they have transmitted, they have spread even more than 3 feet duration, and they have caused infection also. but all these are documented in a defined airspace, that is in a patient's room, inside a patient's room. So even though influenza rhinovirus or droplet, it should not have traveled more than 3 feet, but they travel and they remain suspended in the air also for some time, but only in the defined airspace. It will not come out of the patient's room. So these are the nuances which we need to understand. And this norovirus transmission. So norovirus, we know that it usually causes gastrointestinal infection. So a gastrointestinal infection usually transmits by contact, but from there it can even generate aerosols. So that is what is documented. So which is usually spread by a contact, it can even generate aerosols, and that can lead to airborne infection. And from the environment. So this is the most common mode of transmission, most important organisms which transmits by airborne. Apart from this, from the environmental sources like anthrax spores. So we know that anthrax spores are the infective form of anthrax disease. So a human who is having anthrax infection will not usually produce a spore. So a human person to person transmission is usually not seen with anthrax. So the person to get anthrax, usually it comes from the environment. So anthrax spores, so that can go and suspend in the air, and it can spread as airborne, as well as spores and Legionella. So all these can come by airborne transmission. So before going into the precautions or prevention aspects, CDC specifically defined few organisms, like few criteria for naming them as epidemiologically important organisms. So all these precautionary measures, they specifically categorize organisms for epidemiologically important organisms, like Clostridium difficile, MDROs, multi-drug resistant organisms, agents of bioterrorism, prions, SARS-CoV, monkeypox, norovirus, and hemorrhagic fever viruses, and many more. So they have more propensity for transmission and resistant to therapies. And common or uncommon microorganisms with unusual patterns of resistance and difficult to treat organisms. Some organisms are innately resistant to multiple drugs. So association of serious clinical disease, a newly discovered or re-emerging pathogen. So all these are considered to be epidemiologically important pathogens in terms of precautionary measures. So what are the different precautions we need to prevent transmission of these infective agents? So standard precautions. So this we know already. So previously it was named as universal precautions. It was already revised as standard precautions. Now it is only standard precautions. It applies to all patients in healthcare settings regardless of the documented or confirmed diagnosis. So even if there is no suspicion, the standard precautions holds true for every single person or every single patients. So multiple wings are there for standard precautions, like starting from hand hygiene to PPE, environmental controls, laundry, needles or shops management, patient placement, safe injection practices. So multiple aspects are there for standard precautions. So as per the guidelines, when it to be applied for all patients, all residents, we need to apply standard precautions. And if there is any potential exposure to blood, body fluid, or directly to mucous membrane or non-intact skin, in that case we need to use PPE. So depending on the anticipated exposure route, we need to select a PPE and then use it. No restriction for room restriction and other things are there for standard precautions. So now coming to specific transmission based precautions. So standard precautions apply for every person. So transmission based precautions apply for specific group of patients. So 3 modes of transmission we already saw about. So for all these things, specific transmission based precautions are available. So for patients who are known or suspected to be infected or colonized with infectious agents, including certain epidemiologically important pathogens which require additional control measures. So standard precautions alone may not be sufficient to control these kind of organisms. So for this, even if we suspect, we need to initiate the precautionary measures without even confirming the diagnosis. So contact precautions, droplet precautions, and airborne precautions. So used when the route of transmission is or not completely interrupted using standard precautions alone. So another important aspect which I would like to include here, and I would like to discuss that aspect, was The adverse effects because of this transmission-based precautions. In recently one of that hand hygiene study, a feedback I got was if you do hand hygiene after touching the patient might take it in a wrong sense and it can be like a stigma. So that can affect the performance of hand hygiene in the healthcare system. So similar to that, transmission-based precautions also has been proved to have many adverse effects when it was implemented in the healthcare system. Like it leads to anxiety, depression, or mood disturbances, perceptions of stigma, reduced contact with clinical staff. So clinical staff may not visit often, so they may not identify the problems at the time, and it increases preventable adverse events. So the adverse events which would have been prevented easily, that also has increased because of all these transmission-based precautions. So we should even keep this in our mind when we are implementing transmission-based precautions strictly in our institution. So contact precautions. Presence of excessive wound drainage, fecal incontinence, or other discharges from body. So contact precautions can go little extreme, but it is recommended for specific situations, not for all situations. So usually it is recommended as a single patient room is needed. So each patient should be kept in a single room, but it may not be possible. Then in that case we have to cohort them. Cohort them means the persons with same infections can be grouped together in a room. 3 or 4 beds can be kept in a room, so all 4 patients can be of same infective organism, or they can be kept in a corner of a ward without much contact with the other patients. If multi-patient room, so 3 feet spatial separation between beds. That is what has been suggested even for contact precautions. So gown and gloves for all interactions that may involve contact with the patient or potentially contaminated areas in patient care environment. So always they need to wear a gown and glove when they have contact precautions in place. So before entering into the room they need to don the PPE, and before exiting they should remove the PPE. So these are the organisms where it was suggested. So contact precautions from CDC, what they are saying, the hand hygiene is the first and foremost thing which needs to be followed, and usage of gloves as well as gown whenever needed. So use dedicated or disposable equipment or clean disinfect reusable equipment before use on other patient. So for this kind of cohorted area we can keep a dedicated equipment like stethoscope or blood pressure apparatus, thermometers. We can keep it only in that area which need not be reused in other patients area before disinfection. So this is what is about contact transmission. To have a sum up, so it specifically says all residents infected or colonized with MDROs in any of the following situations. All multi-drug resistant organisms need not have contact precautions. So that's what's the thing which we need to take out. So it can be an MDRO like carbapenem resistant enterobacteriaceae, but only if there is presence of acute diarrhea or draining wounds or other sites or secretions or excretions that are unable to be covered or contained by a dressing. In that case, we need to have a contact precaution. For limited time period as determined by, otherwise it can be determined by the institution if they suspect an outbreak of an organism. If outbreak is suspected, in that case they need to have this in place. Even otherwise, there are few scenarios where contact precautions are always mandated, like Clostridium difficile infection, norovirus or a scabies infection. These are all clearly proved to be transmitted by contact. So in these cases, it needs to be implemented. So these are the scenarios when we need to use contact precautions. For these specific infections, if you suspect an outbreak or if the drainage or diarrhea, whichever is not able to be contained by a dressing for an MDRO organism. So these are the situations when we need to use contact precautions. So contact precautions basically, whenever you enter the room, you need to don the gown and gloves. With proper protection, you need to enter inside. While coming out, remove and discard the PPE. So room isolation, definitely room isolation or separate room also is mandated for contact precautions. Another important concept is enhanced barrier precautions. So recently, apart from contact precaution, one more type of precaution called enhanced barrier precaution has been introduced. So here the difference is whenever these kind of high exposure risk is there. So wear gloves and gloves for the following high contact resistant care activities like dressing or bathing the patient or providing hygiene or dressing of the wound. So for these kind of situations they need to wear gown or gloves. In other situations it need not be. So this is what is the enhanced barrier precaution. So here the indications were infection or colonization with an MDRO when contact precautions do not apply. So in the previous slide we saw all MDROs need not have contact precautions. So those patients they need to have enhanced barrier precaution. So wounds are indwelling medical devices. So even that they have included. The patient may not have MDRO, but if the patient is having a wound or an indwelling medical device, in that case also we need to have enhanced barrier precaution. So any patient with an indwelling device, we need to have enhanced barrier precaution. So these are the scenarios as I already discussed. Gloves and glove only when there is a high patient contact. And there is no room restrictions for this enhanced barrier precautions. Room restriction is there only for contact precautions. So this is the sum up of all the three basic precautions. Not basic, like standard is a standard precaution. Enhanced barrier precaution comes in between standard as well as contact. Contact is totally for any room entry they need to wear a PPE and then go inside. So for enhanced, only for these activities they need to wear this PPE. So room restriction is there only for contact precautions. So this is about contact precautions. So now about droplet precautions. So we already saw what are the different organisms which gets transmitted by droplet. So these pathogens, as I already told, they do not remain infectious over long distances in a healthcare facility. There is no need for special air handling or ventilation for these particular precautions. Here also same thing is advocated. A single patient room is preferable. If not possible, then cohorting. So if the patients are put in multiple patient rooms, then 3 feet spacing should be taken care of. And drawing the curtain between the patients' beds also is advised. So here also multiple things are there. That how do we sterilize the curtains and other things? Multiple things are there behind this. But these are the recommendations by CDC. Healthcare worker must wear a mask. For droplet infection, respirator or N95 mask is not mandated. So general mask is sufficient. Patients who must be transported outside of the room should wear a mask. So obviously they can release organisms as a droplet even in the outside environment. So when they have to go out, they need to wear a mask and follow respiratory hygiene. So as always, even for droplet precaution, hand hygiene is the first and foremost thing to be taken care of. The most importantly, the face shield with eyes, nose and mouth coverage is what is specifically needed for droplet precautions. So your mucous membranes exposed ones you are covering. So airborne precautions. Infectious agents that remain infectious over long distances when suspended in air. So this is what is mainly leading to airborne transmission. So all these specific organisms. So they should be placed in a specific room. So airborne infection isolation room. This is the terminology CDC has recently revised. So airborne infection isolation room should have all these criteria. Like it should be a single patient room. There is no question of cohorting, and special air handling and ventilation. Like the air has to be filtered out before sending out. There should be monitored negative pressure inside that room. So compared to the surrounding pressure, inside the room the pressure should be negative, so that from inside none of the organisms will go outside of this room. 12 air exchanges per hour for new construction or renovation, or 6 air exchanges per hour for existing facilities. So it's usually 6 to 12 air exchanges are needed. So air exhausted directly to the outside or recirculated to the HEPA filtration before return for recirculation. So these are the basic things for airborne precautions. Education about use of respirators. So room is one thing. Apart from room, the proper education to the healthcare workers is also very, very important. So if they are using a N95 mask without fit testing or without seal checks, the use of N95 mask may not be effective. So that also has to be educated to the healthcare workers. But there are scenarios, there are situations when it may not be possible to have a isolation in a separate room with a negative pressure scenario. Like that is the common scenario in our country for most of the places. So in those cases, what to be done? Masking the patient. The patient should be asked to wear a mask and placing the patient in a private room with a closed door and providing N95 or higher level respirators for healthcare workers. So these are the simple basic three things we need to follow if separate negative pressure room is not possible. And whenever possible, non-immune healthcare workers should not be allowed to care for these kind of vaccine preventable airborne diseases like measles, chickenpox, smallpox. All these can be prevented by vaccine. So if the person has not got vaccinated, like healthcare workers is not vaccinated or not have this immunity against these particular organisms, then in that case it's always best to not allow these persons to go inside those patients for treatment or whatever aspects. So as again, hand hygiene is the most important thing to be followed, and N95 mask is the one which is preferred compared to a surgical mask. So for airborne it is always N95 or higher, and the doors to the room must remain closed. So apart from this, there are plenty of things to talk about airborne transmission itself. I will not go into the depth of all these things in this today's lecture. So discontinuation of transmission based precautions. This is another important question which is still unresolved as per the criteria. So we have started all the precautions, transmission based precautions, contact transmission precaution, droplet transmission precaution, airborne transmission precaution. But when do we stop it? So it purely, so all these are for limited time only. Standard precautions, it is no limitation. It is for all patients, it will be continuous. For transmission based precautions, it is only for a limited period of time. How do we decide that time? It reflects on the pattern of persistence or shedding of infectious agents associated with the natural history of the infectious process and treatment. So it depends on the treatment, it depends on the patient's response, it depends on the natural history, like usually how often the patients can shed these organisms in the environment. So all these things decides the timing. So for some diseases like diphtheria, if the patient has diphtheria, we need to enforce transmission precautions until the culture is negative or antigen detection test is documented to be negative. So till that documentation, we need to have this transmission precaution. For respiratory syncytial virus, until symptomatic disease is resolved, we need to have transmission based precautions. Another nuances is, in case of immunocompromised patients, all this duration whatever we have spoken till now may not be efficient, because immunocompromised patients are known to have longer periods of viral shedding or any infectious organism shedding. So for immunocompromised patients, these precautions may need to be extended. The duration for these precautions may need to be extended. And the other current thing is, like now the CDC as well as many hospitals are talking about MDROs and MDRO prevention. So we already saw that contact precautions are needed for many situations as well as enhanced barrier precautions if MDROs are isolated in the patient. So how do we decide the discontinuation time? When do we decide? How do we stop the transmission based precautions? So we know that MRSA is only MDRO for which effective decolonization regimen is available, like mupirocin and some drugs are available effectively for decolonization. For other organisms, the decolonization as such, there are not proper drugs available. So how do we eradicate these organisms from the patient? Previously, some guidelines had come for VRE, like if 3 stool culture negative for VRE in weekly intervals, then we can stop precautions like transmission based precautions. But that was an early guideline, but after that multiple studies have done and they have proved that it can even go for more than 1 year period. So there is no clear cut demarcation for the VRE as such. So ultimately what we need to do is, it may be prudent to assume that MDRO areas are colonized permanently and manage them accordingly. So if a person has been documented to have MDRO colonization, then they suggest that always you think that he is having that MDRO permanently and then go with the precautions. Alternatively, an interval free of hospitalization or antimicrobial therapy and invasive diseases for 6 or 12 months before reculturing patients. So you culture and documented. After that, 6 to 12 months, no hospitalization, no indwelling devices, or no antimicrobial therapy for the patient. If you got a scenario like that, and then you are again documenting that in reculture there is no MDRO, then in that case maybe you can stop the transmission-based precaution. But it is quite a big gray area which is being explored now with multiple studies going on, especially for carbapenem-resistant Enterobacteriaceae and stuff. So till now, whatever I have spoken is just like a brief of precautionary measures. So apart from this, these are the fundamental elements needed to prevent transmission in healthcare settings. Healthcare system components like administrative measures. It includes HICC unit as such, and even the clinical microbiology laboratory facilities and multiple other things. So administrative measures, institutional safety culture and adherence to guidelines in the institution. So all these comes as healthcare system components. So that plays a major role in prevention of transmission in healthcare settings. Surveillance of healthcare associated infection. So that is clearly documented to have a very good impact in prevention of transmission of healthcare associated infections. Education of healthcare workers, patients as well as families. So all these needs to be targeted. Hand hygiene is single most important factor. Then utilization of PPE for healthcare worker. Then safe work practices to prevent exposure to bloodborne pathogens. Patient placement, transport of patients, environmental measures, patient care equipment and instruments and devices, textiles and laundry, solid waste, dishware and eating utensils, adjunctive measures like chemoprophylaxis or immunoprophylaxis for the persons, as well as management of visitors. So all these plays a role in transmission of infection. So isolation precautions, we need to actually elaborate on all these aspects. So if possible, I will try to elaborate few of these aspects in the next classes also. So most of my references from the CDC guideline from 2007, and it was recently updated in 2022 in May. So to be successful in isolation precaution, first and foremost, the single most important thing, hand hygiene has to be taken care of. Environmental cleaning and disinfection, enhanced barrier precautions as well as other barrier precautions, other precautions based on the transmissions. Continuous auditing or follow-up. Implementing something always needs follow-up and proper communication to every person. So all these things will assist in the proper isolation precautions to be established in any institution. Thank you.